Thank you very much. Thank you very much for the kind invitation, and it's such an honor to be here with these honorable colleagues and in this fantastic venue. So, working at the Risk Hospital, we of course deal with diseases that have a long-term risk, and I'll speak a little bit about meningioma that I think will add on perspectives to Volker's talk. Meningioma is a chronic disease, and as, for example, Professor Drummond has published extensively, we learn from the follow-up of our own patients, and the meningioma patients experience recurrences, problems with neuropsychology, fatigue, anxiety, and actually patients who have a diagnosis of meningioma are in follow-up, regardless of if they've been treated or not, must be considered as chronically ill patients. And we need to deal with these issues, and one of the most important things that these patients face is the risk of recurrences. 66 years ago, Simpson published on his grading of extent of resection, which is still probably the most important classification. You are all aware of it, of course, and Simpson had a little bit non-systematic follow-up, but his idea was that within 5-10 years or something like that, patients with the most radical Simpson grade resection, grade 1, had approximately 10% recurrence risk. If tumor was left behind, most tumors grew with long-term follow-up. Of course, 66 years ago, there was no scanning, so Simpson grading has been criticized for its shortcomings. There was a very good opinion piece, essay in Journal of Neurosurgery by Ted Schwartz and Mike McDermott, where they pointed out that the Simpson grading is dependent on intraoperative assessment of tumor extent of resection, and there are many subjective and not traceable assessments. And of course, the degree of tumor infiltration into the dural tail and hyperostotic bone are unknown. The way to deal with this in modern neurosurgery is to use something that's traceable, and the IANO recommendations are to use MRI scanning some months after surgery, but then you can only differentiate between gross total resection and subtotal resection, which probably equal to Simpson grade 1, between grade 1 and 3, compared to grade 4 to 5. And we know already that Simpson grade 1 resections could have recurrences. Where we did a small study where we looked into resection margins that were sent for pathology systematically after surgery of meningiomas that grew into major venous sinuses, and found that when we thought we had done a radical Simpson grade 1 resection, the pathologist found free margins only in 42% of the patients, which is a little bit problematic. The next thing that occurs is that when you start following patients for a long time, working in Sweden, or as I do now in Denmark, the authorities keep good track of the population, so we could actually follow patients not only for 10 years, but also for 25 years, and actually up to more than 30 years. What we saw that within 10 years, recurrence rates for Simpson grade 1 and 2 were pretty much like Simpson already found, but when following patients for 25 years, we found that recurrence rates could come up to 40%, and 2/3 of the recurrences came after more than 10-year follow-up. If tumor was left behind, recurrences came early. Now, this is only one small study, so of course one needs to add on more to that. And we started looking into other factors. Obviously, if there is a recurrence, there are tumor cells behind, but the other parameter that can affect growth is, of course, not only the fact that there are cells behind, but the volume of cells, and even more, how rapidly the cells grow. You're all familiar with the NIV1 Ki67 proliferation indices. I'm reminding you of this. We looked a little bit on whether this proliferation index could be viewed as a marker of, as a predictor of recurrence, which is frequently, which had been frequently proposed. Our interpretation was different. Our interpretation was that if there are tumor cells behind, tumor may recur, but Ki67 proliferation index was more a marker of time to recurrence. So if the proliferation index was very high, almost all recurrences came early. Again, small study in need of more validation. And I have a postdoc, Christian Miriam, and statistician Paul Blanche. Christopher Miriam did a fantastic work getting together almost a consortium, a multi-center registry of patients with meningiomas operated the first time, with now more than 8,000 patients, and looking a little bit into these things also in large numbers in a multi-center setting. What we see here is recurrence rates for patients with high or low and intermediate proliferation indices. These are WHO grade 1 tumors, grade 2 and grade 3 tumors. The low and high are grouped a little bit differently with the different WHO grades. But what I think the graphs illustrate is exactly the point I wanted to make from the fact that if there are neoplastic cells behind, they will probably grow sooner or later. If we have the most aggressive tumors, the WHO grade 3 tumors, they reach a plateau fairly rapidly. But if we have the grade 1 tumors, which are, well, much more benign, when they have low or intermediate Ki67 indices, recurrence rates are linear. After 10 years, it's about 10%, like Simpson said 66 years ago. So maybe it's redundant that we redo these studies, but that's what we see. If we have a higher proliferation index, they recur quicker, but they seem to reach a plateau after maybe 7 years. So I would interpret these graphs to say that that the tumors recur and they will probably reach a plateau, and they will reach a plateau at a time where probably all tumors where tumor cells were left behind have recurred. The bottom graphs agree with a time to recurrence for those tumors that recur. Again, we can see that that the tumors with the highest proliferation indices recur early. And this graph shows the same thing from a different angle. Here we have only WHO grade 1 tumors. We have time to recurrence, and we have now difference between Simpson grade 1, grade 2, and grade 3. And these graphs clearly show that there is a fairly large difference between recurrence rates of Simpson grade 1, 2, and 3. The Simpson grade 1s, after 10 years, recur at around 10%. Simpson grade 2, if it's a high proliferation index, almost 40%. If it's lower, almost 20%. Simpson grade 3, even higher. So from a multi-center registry of 8,000 primary meningioma patients, I would say that these figures suggest that the Simpson grading is a grading of the likelihood of remaining tumor cells, and depending how rapidly they grow, we will reach a figure which actually is the likelihood that everything has been removed. And it also indicates that there is probably always a risk of recurrence if there are remaining cells, and we should look more into that. Apparently there is a great need of a traceable way to find out if there are tumor cells left after surgery. And clearly the MRI-based grading, the EANO grading, is insufficient because gross total removal can be either Simpson grade 1 or grade 3, and there were huge differences in how likely it is that tumor cells are left behind. So we were interested in trying to look more into a dichotomized extent of resection. And there are a couple of things that would be interested in looking into direct criteria. And there are some papers out there, and we've also written about the idea of microscopic evaluation of the resection margin, which is used in all other cancer surgery in the body, but we don't use it much in the brain. Maybe this should be taken into account. And the other thing is that there is now a better way to study images of meningiomas. The little teaser up here is histological staining of somatostatin type 2A receptors, because almost all meningiomas express this receptor, and this is a very useful receptor. It's a specific meningioma marker, actually. It's expressed in some other tissues, but pretty specific for meningiomas. And one can use a ligand, a PET ligand, positron emission tomography ligand, 68 gallium DOTATOC, which then will recognize the somatostatin receptor positive cells. Example here where we have a postoperative MRI, which is pretty non-telling. When we combine it with somatostatin receptor imaging here, we can clearly see that there is residual tumor. This has been published by several groups, also by us, but it's pretty well known, and it can be used for the grading. So we have started to use a different grading at our department and with some of our collaborators, where we both send biopsies from the resection margins. We try to do this systematically, and we get a postoperative DOTATOC PET after 3-4 months to grade either presence of meningioma cells in the resection margin, where you can have 1 or 0 depending on whether you find them or not, and the DOTATOC scan, where you can have 1 or 0. This is typically a 1 there. And with this grading, we have just started doing it, but we do it for all our patients. Our preliminary data is that approximately 1/5 of patients where we have intended gross total removal and negative or inconclusive MRI, we find that there is objective traceable evidence of residual tumor, either only by positive dura biopsies or only by a positive DOTATOC PET, or of course some that are positive for both. So this is, in our view, a much more traceable way of grading removal. So what do we do if we find the residual? Well, one thing that we published long ago, and which is along the line of Professor Seifert's idea of combining microsurgery with radiosurgery, which can be done either with an upfront plan or if we find accidental, unexpected residual tumors. We call the tailored resection plus gamma knife radiosurgery Simpson grade 4 gamma, and we've published some results of this. The unique thing with these results is that these are actual control rates after 10 years of follow-up. All patients have been followed for 10 years. It's not life table statistics here. And we can see that with Simpson grade 1 to 2, either for petroclival meningiomas, sphenoid wing, parasagittal, Simpson grade 1 to 2 is approximately 10% recurrence rate or 90% control rate. Simpson grade 4, where there is tumor behind, we see that for all these groups, half or more than half of all tumors continue growing with a 10-year follow-up. If we treat them with radiosurgery up front, we come back to the same control rates as for grade 1. So it certainly supports with statistics Volker Seifert's suggestion of getting tumor control by combining microsurgery with radiosurgery. But this is not the only problem we have. We have a completely different problem now popping up with meningiomas, and some of you asked questions to Volker about incidental meningiomas. And I'm sure you all know that between 1 to 3% of the adult population harbors incidental meningiomas. In Denmark, somebody made a study where the incidence of benign tumors detected was directly proportional to the number of MRI scanners in the country. And as more and more people get scanned, of course, we will find more of these. This is a huge problem because if we don't operate them, we will need to do annual scanning. And I cannot calculate how many scans this would be in China every year, but I mean, it's probably makes a good living for a lot of radiologists. It's a costly logistical challenge, but that's not the only thing. Patients who have had a diagnosis of a meningioma also become chronically ill when they do. This is a study that shows that quality of life patients who have an incidental meningioma are followed without treatment also have really bad quality of life, which is similar to those that have been operated and who may have complications. So I was talking about PET scanning. So I'm proposing also a solution for this, because there is a PET ligand which is a pretty good predictor of tumor progression. The FLT PET, the FLT uptake correlates pretty well with tumor growth, and it correlates well with a Ki-67 proliferation index. So this appears to be a promising way to select which patients may benefit from surgery, and again, which patients may be told that you have a very low FLT uptake, this tumor will not bother you, we will not need to do follow-up. Of course, we need prospective studies, but I would propose that this is something that maybe could be done together with our colleagues in China and within the framework of Wang. So starting to sum up, there have been some recent claims on Simpson grading extent of resection, and I think it's clear that Simpson grading cannot predict the risk of recurrence. It's the residual volume and the growth rate, and there is zero risk if there is no residual. Others have proposed that Simpson grading is dated, and there are papers out there that say that recurrences are similar across Simpson grades. This is only true if there are small series and short follow-up. Others have proposed that MRI can be replaced, that the Simpson grading is fully replaceable by MRI definitions of gross total resection and subtotal resection. Again, I argue that sensitivity and specificity are not sufficient for that, and there's a huge problem that Simpson grade 1 to 3 are all gross total resections. So my proposal for PET-CT in China for meningioma patients, I think are very realistic. There is a huge number of PET and CT scanners in China, but I think mostly they're used for FDG PETs and not very much for DOTATOC PET, maybe, and probably not FLT PET for meningioma patients. So I think there is an opportunity. So extent of resection, there's a high risk of remaining tumor despite Simpson grade 1 to 2 or gross total resection. Simpson grading is problematic because underlying data are not traceable. MRI-based grading lacks specificity and sensitivity. I propose histology and PET imaging, and I think it would be very nice if we could universalize something like the Copenhagen grading, where one looks at histology and DOTATOC PET imaging. And PET imaging is really promising, with both looking at the somatostatin type 2A receptors with gallium DOTATOC, and maybe try to classify incidental meningiomas with FLT PET. Thank you.